Good morning, everyone. It's really my pleasure and my joy to be here. Let's move on this talk about the salivary gland cytology and the diagnostic challenges and tips. No conflict of interest. For the basic, we have to define the ABC of salivary cytology. So architectural pattern, the background, and of course the cytomorphology. And this is important because if you look at the histology of salivary gland, you can see how many different types of cells, acinar, myoepithelial, intercalated duct cells, striated duct cells, excretory duct cells. And from each of them, we have different benign and malignant entities. And the issues are very well reported in these tables from TIAG&A, in which you can see all the diagnostic problems, including sampling error, smear cellularity, the heterogeneous nature of salivary gland neoplasms, the fact that low-grade neoplasm may mimic normal salivary glands, the impossibility to define benign and malignant nature of some lesions because you are not able on cytology to define capsular and vascular invasion, the lymphoid and rich, the lymphoid and cystic lesions, and also the overlapping cytological features, hyaline globules, clear cell pattern, squamous metaplasia, oncocytic changes, and spindle cells, which can be seen in benign and malignant entities. And it's important for this cytology to consider the background in terms of quality and quantity, but also the different type of cells, as mentioned it, that we might have in different architectural organizations. In 2019, we published the first, as you know, Milan system. In 2023, the second edition with more chapters, more authors, more pictures, and revisions according to the WHO had an act because Dr. Faquin and I were involved in this WHO, and also changes in the risk of malignancy and updates in the ancillary chapter. This is the core of the Milan, in which you can see the categories with the entities combined with the risk of malignancy and management, and the pretty high statistical evaluation reported according to the different papers included for the definition of the Milan system, first and second edition. But let's focus on something more morphological, and to narrow the diagnosis, we need to define the architectural and cellular pattern, which can be tubular and cribriform, squamous and spindle, mucin and other secretions, epithelial and lymphoid component, high-grade cytology, including the oncocytoid appearance of the cells, and then cystic lesions. Each of them will be introduced by the evergreen plants because I liked to give this association with plants. Tubular and cribriform, you can see how many different entities, but most of them are basaloid pattern, adenoid, cystic, polymorphous, basal cell adenoma and carcinoma, AP-myoepithelial, pleomorphic adenoma, and microsecretory carcinoma, the new entity introduced by the WHO with a specific MEF2S SS10 rearrangement. Concerning the adenoid cystic carcinoma, as we know, we have different patterns, including cribriform, but also the tubular and the solid. In the cribriform, we have these basaloid cells surrounding this mucopolysaccharide component. The solid pattern is very tricky because we do not have the stromal component, and mostly it's a layer of basaloid cells with a scan cytoplasm, high nuclear cytoplasm ratio, angulated nuclei. This is the thing that you have to consider. Small nucleoli, occasionally mitotic figures, and this mucopolysaccharide material is hyaline, pale, translucent, with this bubblegum appearance in the diffquick or light green in Papa Nicolau. You can see the three different patterns: the tubular in the upper left, the cribriform, and the solid, which is really difficult to distinguish from basal cell adenoma and carcinoma. And if you have enough material, you might perform immunostains. Positivity for CD117 membranous and cytoplasmic, and the typical nuclear positivity for the new molecular immunomarker MIB and cell block, or also on, for instance, LBC stored material. Another tricky entities in this group is polymorphous adenocarcinoma, 26% of intraoral malignancy, pretty slightly female prevalence, mean age, mostly in the palate. It is defined by a uniform cellularity and a very heterogeneity concerning the architectural pattern. We might have these cells with very small basaloid, vesicular chromatin, sometimes nucleus inclusions, and very small stromal metachromatic stromal component. And you can see here the variability of the architectural pattern that you can see in the slides, including papillary, three-dimensional, follicular, or a diffuse pattern. You might be supported by a specific hotspot mutation in PRKD1, which is useful if you have material to perform on cytology too. Here you can see all the other entities with a tubular and cribriform basal cell adenoma and carcinoma, in which we have this basaloid appearance of the cells, strong nuclear positivity for beta-catenin due to the CT and NB1 mutation, canalicular adenoma, which is usually monophasic, hepimyepithelial that we are going to see, and of course the pleomorphic adenoma, which is defined by chondromyxoid stromal component embedded by myoepithelial cells and the epithelial ductal luminal cells. Here you can see the evidence of a basal cell adenoma or carcinoma. This is a basal cell adenoma in which we have these basaloid cells and the scant cytoplasm and this haphazard organization of cells, and also the typical positivity nuclear for beta-catenin. This is in the hepimyoepithelial carcinoma, biphasic lesion. We have the ductal component, but also an exuberant myoepithelial component, usually defined by clear cell pattern. It is typically associated with this laminated concretion of protein, which, as you can see, are different from the adenoid cystic carcinoma because we do not have the cells back to back at the periphery, and is mostly acellular. Concerning, of course, another support that we haven't reported in the Milan system is the possibility for this basaloid pattern to define the immunostains, which might be specifically useful for the different entities. Holea for introducing the spindle cells. This is a very challenging part of the cytology and histology for head and neck, and including the salivary glands. We might have different appearance, monomorphic, pleomorphic, biphasic, and myxoid. According to when we have a spindle cell pattern, we have to define if it is benign, so preserved cells, monomorphic nuclei, few mitotic figures, collagen framework, or malignant, in which we have the typical features of malignancy, necrotic component, pleomorphic nuclei, mitotic figures, and loose cell clusters. And when you have this, you can define if it is also a low grade with very bland atypical features, or high grade with a significant pleomorphic pattern. Concerning the spindle lesions, as you can see, we might have many different entities in the benign, but also in the malignancy, including primary. And I would like also to stress the fact that especially in the parotid gland, we might have a metastatic localization, which is mostly due to the evidence of the intraparotid lymph node, as you know. It is sometimes not possible to give a specific diagnosis of a spindle lesion, but we are able to define if it is benign or malignant due to the features of the cells. It's important always the correlation with the clinical history, of course, size, age, growth pattern, and also to have material in order to perform the immunostains. When we discuss the malignant features also in spindle, you can see we have the typical malignant features: high cellularity, nuclear hyperchromatia, prominent nucleoli, irregular chromatin distribution, pleomorphic features, necrotic component, hemorrhage, and atypical mitotic figures. One of the most typical with this spindle appearance due to the variability of the cells is myoepithelioma, because we might say that myoepithelial cells can be clear pattern, epithelial, plasmacytoid, and also spindle. Usually 50% in the parotid, we might have eccentrically located nuclei and positivity for CD, cytokeratin 14, P63, S100, and SMA. And you can see the appearance, which can be spindle, but also plasmacytoid. The counterpart is the myoepithelial carcinoma, very rare, less than 1% of carcinoma, usually ex novo or has the malignant component of a carcinoma X pleomorphic adenoma. We have to say that the morphology can be very variable. It's a population of myoepithelial cells with sometimes a bland cytology resembling a myoepithelioma, or in other cases with atypia and with mitotic figures, and as in the bottom, in which it's not so difficult to recognize that this is a malignant lesion. Another possibility is, of course, a high-grade MAC with these marked epidermoid cells, in which you can see some sort of a spindle component, and you can see the malignant features of this entity. Let's move on the mucinous pattern. Mucinous pattern can be seen in benign entities such as Warthin tumor, which can be very tricky. We will see a case later in the afternoon, but also MAC, mucinous adenocarcinoma, but also the mucinous evidence in some other entities such as myoepithelial carcinoma, salivary duct, clear cell carcinoma, and the microsecretory. One of the most typical is low-grade MAC, in which you can see we have the typical features of this mucoid component, but also cluster of cells in which we have mucus-producing cells intermingled with squamoid cells. Usually the epidermoid cells are very bland, and this is typical in the low-grade MAC. We have to say that the background can have a lymphocytic component in 20% of the cases. Why it's so difficult, the low-grade MAC? Because it's a common cause of false negative result, due sometimes to the FNA itself, because we have only cystic component, bland epithelial cells resembling histiocytes. So be careful when you have only mucinous material. And you can see many differential diagnoses, including some benign entities, chronic sialadenitis, squamous and mucinous metaplasia, but also some cystic lesions, pleomorphic adenoma, and some malignant entities for which you have the typical features, of course, of malignancy. Another important entity is a secretory carcinoma, in which we have these cells, very bland, single follicular papillary architecture, very bland cubical polygonal cells with low nuclear cytoplasm ratio. The typical features is the evidence of vacuoles, roundish vacuoles in the cytoplasm, and nuclei which are eccentrically located. It's a typical positivity for mammaglobulin, E-cadherin, and also has-100, and the typical translocation, which is ETV6 and TRK3, seen only in secretory carcinoma. The epithelial clusters with the lymphoid background. We might have some benign entities, intraparotid lymph node, a reactive intraparotid lymph node, lymphoepithelial sialadenitis, in which you have to recognize the lymphoepithelial cluster, so squamoid ductal metaplastic cells intermingled with small lymphocytes, or the lymphoepithelial cyst, in which we have a single or multiple cyst, glandular and squamous lining, hyperplastic lymphoid tissue. But I would like also to mention that there are many different entities in which we have epithelial component associated with lymphocytes. Warthin tumor, in which you have to recognize three elements: dirty background, lymphocytes, and oncocytic cells. Mucoepidermoid carcinoma, as mentioned before. Acini cell carcinoma, in which we have this lymphocytic component in 30% of the cases. Sebaceous adenoma and carcinoma. Lymphoepithelial carcinoma, which is an high-grade carcinoma with also this small lymphocytes percolate in the cluster, secretory carcinoma, and a metastatic localization, especially in the parotid. Actinic cell carcinoma is a very bland cytology, uniform population of cells with this granular zymogen-rich cytoplasm, pass positive diastase resistance. As you can see, very bland, round nuclei with this pale chromatin and small nucleoli, minimal nuclear pleomorphic features. It's very tricky because it might resemble a benign entity such as the normal salivary tissue. We might have the support of immunostains, the new NR4A3 nuclear expression, DOG1 cytoplasmic and membranous, and the SOX10 nuclear positivity. As mentioned, the lymphoepithelial carcinoma, this is very tricky, although you can recognize as an high-grade carcinoma. It might resemble a nasopharyngeal carcinoma too. You can see this very high-grade, poorly defined cellular borders of the cells percolated by small normal lymphocytes. Let's move on by large cells and abundant cytoplasm. Without atypia, warting tumor, as mentioned before, oncocytoma, and actinic cell carcinoma. With atypia, one of the top is the salivary duct carcinoma, high-grade MAC, poorly differentiated carcinoma, non otherwise specified, usually adenocarcinoma. This is a diagnosis of exclusion, and metastatic lesions. Here, just for showing you the differences between a warting tumor, in which you can see this dirty background, lymphocytes and oncocytic cells, and oncocytoma on the right, in which you can see you have only this population, usually three-dimensional, of oncocytic cells. Many differential diagnoses also for oncocytoma, nodular oncocytic hyperplasia, usually hypocellular. Warting tumor, as mentioned before. The oncocytic subtype carcinoma, in the last WHO we excluded the oncocytic carcinoma, but we defined the oncocytic subtypes of many different carcinomas and actinic cell carcinoma. And sometimes it's very difficult. If you look at these two pictures, on the right, on the left, you have an oncocytoma. On the right, you have an actinic cell carcinoma, and the only difference is in the crowded population, but the cells are pretty similar and pretty bland in both of them. Also in this case, if you are lucky enough to have material for these oncocytoid appearance, you might perform specific immunostains, which can be helpful for the diagnosis. With atypia, of course, the first is salivary duct, and you can see it's a typical cytology. We have these three-dimensional clusters of cells with overtly malignant features, anisonucleosis, well-defined cell borders, differently from the lymphoepithelial carcinoma, in which we have poorly defined cell borders, enlarged nuclei, and also hyperchromasia, mitotic figures, and necrotic component, and very big nucleoli. You can see the necrotic also component here. Many differential diagnoses, MEC high grade, but in MEC high grade you have these mucus-producing cells and these high-grade epidermoid cells, primary or metastatic squamous cell carcinoma, lymphoepithelial carcinoma, carcinoma with oncocytic component, as mentioned from the new WHO, poorly differentiated carcinoma, especially the neuroendocrine type. We have to remember that we might have neuroendocrine component in salivary gland tumors. Carcinoma X pleomorphic adenoma, in which we have the component of the chondromyxoid stromal component, but the epithelial malignant component of an entity, so mixed component. Adenocarcinoma NOS, this is a diagnosis of exclusion, often try to locate the entity into a specific, of course, diagnosis and metastasis. I would like briefly to mention this, squamous cell carcinoma and salivary gland. Usually, when we have a squamous cell component, we have to think in this order. Firstly, that this might be a malignant squamous component of an high-grade MAC, and look for the even focal mucinous cell component. Metastasis from a mucosal or cutaneous squamous cell carcinoma in head and neck. then or a squamous mass from a distant primary carcinoma, and then as a last diagnosis, as a diagnosis of exclusion, a primary squamous cell carcinoma of the salivary gland, which is really a very rare entity. Some tips for metastasis. It's important the correlation with the clinical history and radiological finding. So if you see binucleated cells, intranuclear pseudoinclusion, some pigment in the cytoplasm or in the background, just keep in mind the possibility of a metastatic melanoma and ask for clinical information. Or if you see keratin debris, atypical squamous cells, necrotic background, look for the clinical history and ask if there is a squamous cell carcinoma someone else had or distant, as we mentioned it. If you see clear cell features, just keep in mind that we might have a metastatic clear cell carcinoma from the kidney, and the lapse can be even decades. So just ask for this clinical information. Of course, also in this case, for the high-grade lesions and metastasis, we might use immunostains to narrow down our diagnosis. Just for mentioning that we might have solid but also cystic lesions, and in this we have to focus on, firstly, if it is mucinous or not mucinous component. If it is mucinous, try to identify if it is neoplastic, and usually if it is neoplastic, it's a low-grade MAC. If it is non-mucinous, just define if you have a lymphocytic component or a non-lymphocytic component. In the lymphocytic component, try to exclude that this is a lymphoepithelial cyst or a Warthin tumor. In non-lymphocytic, inflamed cyst, benign cells, or neoplastic cells, usually try to exclude a metastatic localization, especially in the parotid, but of course, not only. It's important to focus on the fact that also in cytology you might perform ancillary technique with feasible and reliable results, and you can see here a table of many different tumors, benign and malignant, associated with specific alterations, which can be rearrangement, amplifications, mutations, and in some cases they are pretty useful because they are associated with 100% of the cases, such as secretory carcinoma and the ETV6 and TRK3. So in conclusion, we can say that HFNA has a very high diagnostic accuracy in the management and in the diagnosis of salivary gland lesions. The application of diagnostic criteria and pattern is of course essential for the interpretation, as well as it's important to use a classification system, and right now the unique is the Milan system, has the combining the entities into categories with the risk of malignancy and management. Of course, you have to interpret the lesion in the clinical and radiological findings. Remember that based only on morphology, you might have some false negative and false positive result due to the overlapping of many different features, such as the hyaline globules, which can see in adenoid cystic carcinoma, but keep in mind that in 10% of the cases that can be seen also in focally in pleomorphic adenoma. So this is not a unique feature of the adenoid cystic carcinoma, for instance. The Milan system, we are very proud because was endorsed by the WHO Histology of the Neck and by the American Society of Clinical Oncology. And with this heart that I found in one of my recent case in salivary gland, I'm very nice. Thank you so much for your attention, and I'm open then for any questions. Thank you so much.